Good evening. My name is Rick Ward. I'm Medical Director, Primary Care for the Calgary Zone with AHS. Welcome to our second in what may be a series of educational events that is targeting primary care to give you the latest and the greatest in what's happening with the COVID epidemic. I'm joined today by four outstanding colleagues. Had trouble with the count initially. We've got representation from the primary care networks, Dr. Christine Luelo. We have got our all-star psychiatrist, my friend and classmate, Margie Oakander, who is here to talk about the mental health side of the COVID epidemic. We have John Gill, infectious disease expert, who is going to give us the latest in the science of the COVID epidemic and particular relevance to primary care. And last but not least, we have Dr. Jia Hu, who is Medical Officer of Health, who will give us an update from the public health perspective. For those of you who are logged on live, keeping in mind that this will be archived for later viewing, there is the ability to submit questions. We've had some questions already, but we want to make this as interactive and as practical as possible, so please send those in. The background of this program is that we recognize that primary care needs as much information to be able to deal with really the front face of this crisis, and that there are many different perspectives that are really necessary to fully understand what's happening and to be able to manage this in the medical home. This is the second iteration. We plan to do this on a weekly or bi-weekly basis until the seas have calmed. Stay tuned in the usual communication sources to hear the details on that. The last point that I'll make before turning it over to Christine is that we have received notification from the Alberta College that those of you who are family physicians who are registered and when accreditation is of interest to you, we've been granted 2.0 study credits for each of these sessions. So for those of you who attended last time, you'll be getting an email in the next 24 hours giving you the details on that. The ACFP has responded to the unusual times and has helped us streamline the accreditation process, which is a great service to members. So without further ado, with social distancing respected, I will turn things over to Dr. Christine Luelo, the South Calgary Primary Care Network Medical Director.
Thanks, Rick, and thanks everyone for joining us tonight. My job here tonight is just to talk to you a little bit about the PCN response to date and what we've got in the works for the next several weeks. And as Rick mentioned, we hope that we'll be able to deliver some more of this practical advice for you moving forward. So the PCN response to date has been, we have struck a weekly pan-PCN and key partner huddle, which involves all 7 PCNs in the Calgary zone, as well as representation from Alberta Health Services and the Alberta Medical Association and Alberta Health. We have been publishing a weekly pan-PCN newsletter that has information about our planning activities, as well as some practical tips for you as you operate in your clinics. And as Rick mentioned, this is our second of 2 CME events, and we hope that we should be able to bring more of these forward for you in the future. We also are working on best practice advice for community clinics, so there'll be more of this coming, and we'll touch on a few things today as part of our talk. So one of the big questions that we have coming to us is keeping my office going during a pandemic. These are times that none of us have prepared for. Even the most prepared clinic is not going to have something in the books to do this. So one of the things we want to keep in mind is patient care should always come first. We are, as physicians, as care providers, all in this for our patients. And so we want to always, when we're having stress, when we're having anxiety, take ourselves back to that. Patient care should always come first. The College of Physicians and Surgeons of Alberta, the Office of the Information and Privacy Commissioner, and the Canadian Medical Protective Association all understand that this is a pandemic. You will be judged by what a reasonable person would have been expected to do under the same circumstances. So please consider this as you move forward in how you care for your patients. Another key point we want to remind doctors about is consider holistic risk. And this was a great statement that was made on the ACFP webcast earlier this week. So the idea is if I'm seeing a patient virtually, so over the phone or by video conferencing, and I'm thinking, is this a sinus infection? Is this just their allergies? Do I need to physically examine them in order to know the difference? And what's the risk if I don't examine them in the office? So if I give them a prescription for an antibiotic that they maybe didn't need, and in fact it was just allergies, is that more or less risky than bringing them into my office and potentially exposing them to COVID along the way? Remember to use your judgment. You're all very smart, trained professionals, and you need to remember that as you, again, feel that anxiety, and remind yourself, just go back to your first principles. I remember when I was a resident in my training and was going to one of my first codes, my chief resident said to me, always take your own pulse first. Take a breath and move on with what you know and you've been trained to do. As you move forward with your office, we understand that funding for the care you're doing has changed, and that's caused a lot of financial hardship. Remember to keep essential staff to populate your schedule and manage any face-to-face visits that you have. You can't do virtual care if no one is answering your phone and booking patients into your schedule. Remember to update your phone message and website so patients know you are still around. And this aligns really well with some work that's happening just today with the AMA, as well as over the next week here, to make sure that Albertans know that their family doctors are still ready and willing and able to care for them in their medical home. So I just want to talk for a moment about virtual care options. There's great information on the virtual care webinars that are now posted on the AMA website, as well as links to a FAQ document from those webinars, but some basic things to keep in mind. Think about your current workflow and what you can start doing right away. Everyone can do a telephone call, so we already do those. We've already been billing for those in our normal care. We're just doing more of that. If you are going to use telephone only, start collecting emails to get ready for the jump to video once other platforms become available, or as you research platforms that are already in existence. And I want you to remember the difference between three different things. There is unsecure, things like FaceTime and the basic Zoom package that we can use during the pandemic and with the pandemic codes, but this is unsecure. There's also secure, such as Doxy, and you can use this during the pandemic and only with the pandemic codes, but it is not regulated, and therefore you cannot use the 03.01T and S codes that are for regulated, secure messaging and video conferencing with your patients, which takes me to regulated, something like Medeo or Zoom Health, which is the AHS offering, which has a pre-existing contract under, or PIA in place rather, that has been vetted by Alberta Health and the OIPC and has very strict criteria around it. Those are the platforms that some of you may have been using to date and you can continue to use, but we have some other opportunities during the pandemic. PIA amendments are not needed, and we are working on a template to allow you to email OIPC to let you know in brief that you're making the change. Consent must be obtained at least verbally, and scripts are available through CPSA, and also please make sure to chart that in your chart note with that call. We'll be sending out links after tonight's event in our FAQ document that have the links to these different things that I've referenced. So what's next? We're in stage 1 right now, and this is in regards to an AHS planning document. Stage 1 means that we're only doing urgent visits face-to-face, and we're doing non-urgent visits by phone. PPE is being given out to all clinics at this stage through PCNs. Stage 2 comes next, and we will be continuing to manage urgent general medical needs of our panels. Urgent visits may expand as we try to keep patients out of emergency and urgent care facilities where they will be more overwhelmed. And as ambulatory care clinics for specialists start to wind down their activities to focus their attention on acute care activities. So we'll be seeing more of our patients who normally see their specialists for their specialty care needs, but we'll be getting more phone advice through specialist access through Specialist Link. And finally, stage 3, when we have the maximal number of patients admitted to hospital, acute care all of the specialists, et cetera, have been redeployed to acute care needs, and we'll be having increased number of patients affected by COVID, whether that's with a positive swab or a presumed positive case without swabbing. And so we're working on care maps for family practitioners to help guide decisions for care of those patients in their homes and through the medical home. We will also be looking at ways to support patients who have been discharged after their COVID care treatment in hospital. All of this is being done. We had a 2-hour meeting today where we're actively in the planning phases for that and hoping to see more with implementation starting early next week. But we're using this philosophical framework for planning, and we hope that this aligns with what you would expect from your PCNs. So that's it from the PCN update, and look forward to any questions that may come forward through the chat line. At this point, I think we're handing the microphone over to Dr. Oakander. Meg, over to you.
Thank you for having me. My name's Margie Oakander. I'm a psychiatrist that I work up at the Sunridge Primary Mental Health. I'm part of shared mental health care. And usually, for those of you that have heard me speak before, I'm usually talking about mood and anxiety disorders, comorbidities, pharmacotherapy, but tonight is going to be a very different and very short talk on how to build your resiliency through this pandemic. Some of you might be feeling a little bit like this, perhaps. And what I want to do is build on the wisdom and the strategies that you're using already to help you give a greater sense of control and a greater sense of being able to cope. And these strategies will work for yourself, and as I say, you're probably using many of them already, and they'll also help with your patients, because your patients will be coming to you asking for support and asking for tips. I have to say that putting these slides together, I canvassed a number of my colleagues, family practice colleagues, psychology colleagues, psychiatrists, and so I've distilled that and a lot of information that I've been reading over the last few weeks and tried to really pull it together for you in a very quick little presentation. So if we want to start off with sort of basics, it's fighting fear with facts. So it's looking at trusted sources of information. Where can I get my information? And of course, the AHS website is sort of the truth, if you will, as we know it today. I'm also finding the updates with Dr. Dina Henshaw, our Chief Medical Officer, really valuable on CBC. We want to keep a perspective on the risks, and I keep relating back to what Dr. Gill said a couple of weeks ago, that 80% of individuals that get COVID will have mild to moderate symptoms and not require medical intervention. And so when my patients are asking me and worried about that, those are the statistics that I'm giving them to try to keep the risks in perspective. We want information. We don't want to be inundated. And I was out at a family practice clinic today, and one of the family docs said she's just had to turn off her feed, a lot of her social media feeds. And so she is saying, I am getting too much information from too many different sources. I need to shut down the social media. I need to limit what I'm getting. So really turning off the news and limiting that. And taking a media break can be very helpful. And I think you've probably heard that from a number of different areas. When we look at physical distancing, not social distancing, I think that term's been changed in the last few days. We want to stay socially connected. We want to plan phone and Skype meetings with our friends, with our families. And there's lots of neat ideas, actually, that are coming out. I heard about a Tolstoy book club where people are making their way through War and Peace over the next several weeks. There's lots of exercise groups. There's lots of things that are going on that are really kind of fun and interesting that help us keep socially connected. It's so important. Maintaining a routine, well, that's a tip that I discuss with patients even when we're not in the middle of a pandemic. So keeping that sleep and wake schedule, sleep hygiene, maintaining meal times and healthy eating, building in an exercise routine, building in social time. So if we look at exercise, part of the routine for physical and mental health, we know that physical exercise has level 1 evidence for the treatment of depression, for mild to moderate depression. So it's going to be really important as we go through this pandemic to maintain those routines. We know that there's lots of tips on how to exercise at home. One of my favorite YouTube videos is the Yoga Vidya. I'll do a shout out for that one. It's free. So there's lots of things that we can be doing to keep up the exercise routine. And getting outside. Have you noticed how many people are outside walking? They're walking their dogs and their kids, and that is getting out in nature. David Kessler, who is a grief therapist and expert who worked with Elizabeth Kubler-Ross, of course, the famous grief guru, if you will, talks about collective grief being in the air, and that is around themes that the world has changed. There's a loss of normalcy, the economic toll that we're taking, plans being canceled, fear of physical danger, all of those things is that collective grief. And we can label this as a time of grief. And I guess it's okay to feel the feelings, feel the anger, feel the fear, let it wash over you, and then take the time to process that. That if we see this as a grief response, then we can somehow deal with that more readily with our strategies. So if we look at the stages of grief, I'm going to go through these really quickly because I think it's interesting how it can apply to this pandemic. The idea of denial, and I met somebody on the weekend who was still in total denial. This virus isn't going to affect us. It's not that bad. It's just the flu. Anger, you're making me stay home, or the government isn't helping me as a physician. I'm feeling attacked. The bargaining, okay, if I distance for a couple of weeks, it's going to be okay, right? And then the sadness around I'm going to go bankrupt because my family practice is shut down. I don't know where this is going to end. And then finally, acceptance that this is happening. And Kessler says that when we have acceptance, that's where the power lies. That's where we find some control, and that's where we can start doing things such as saying to ourselves, I can wash my hands, I can keep the distance, I'm going to keep seeing patients virtually, I'm going to learn how to work with that, and when this is over, patients are still going to need me. Kessler talks about finding meaning in this, so finding meaning, sort of a light at the end of the tunnel, and that's very important to be appreciating the things that we have, the social connections that are cropping up. People are talking more about how they're reaching out by phone and hearing people's voices, walking in nature and all of that. So with anticipatory grief, going to the future and imagining the worst, we have CBT strategies around that. And I garnered some of this cognitive behavioral therapy input from colleagues who work in that area and talking about combating negative thinking. So finding balance in what you're thinking by opposing negative thoughts with positive ones and remembering that there are truly wonderful things in the world. Online CBT tools, and I actually gave a couple of these to patients today. Bounce Back and Mood Gym are both excellent CBT online websites that patients can utilize. Developing positive mantras, we'll get through this, the best brains in the world are working on this. There's lots of acts of compassion, and stocking up on compassion because people are stressed, and I think we're suggesting that we just cut people some slack and be patient. From DBT, and I got some of these ideas from Sarah Lazaruk, one of our DBT therapists at the clinic, and also a colleague, clinical psychologist, Daphne Wing, who does trauma-informed therapy. Some really excellent ideas. So progressive muscle relaxation is the MindShift app, and that's the little blue square on the right. Paced breathing, which is another tool from DBT. So that's inhaling through your nose and exhaling long exhales through pursed lips. And what that does is it lowers heart rate and activates the parasympathetic nervous system. And there's an app for that, the Paced breathing app. Grounding, which is another DBT strategy, so naming 5 things in the room, grounding yourself in space. A strategy from EMDR is the butterfly hug, and you'll see a picture of a woman doing that in the bottom. That's a nice little video on this strategy that incorporates EMDR tapping strategy. It was a strategy used with survivors of a hurricane a few years ago, and there's lots of information on that, the butterfly hug. So there's strategies from all sorts of different areas. If we look at mindfulness, and I got some of these ideas from a colleague in St. Albert, Dr. Patricia Simpson, who's a psychiatrist. If we look at mindfulness, that's coming into the present and being aware of sensations and breathing. Dr. Simpson's favorite website is Tara Brooke. I use the Palouse Mindfulness, which is a little more detailed 8-week program, so maybe not as geared for the beginner. And with the Calgary connection, the Breath Project, Dr. Phil Bluestein, gastroenterologist here in Calgary, and Dr. Alan Donsky, pediatric psychiatrist, developed the Wellness Through Mindfulness program. So there's some excellent programs here in Calgary. Another CBT program that I want to mention Dr. Wachuku just gave me, and I should have mentioned this, I don't have a slide on it, is the Text for Hope through Alberta Services. So you text COVID 19 HOPE, and you text to 393939, and you can subscribe, and you can get 3 months of cognitive behavioral therapy text messages. So I'm going to be checking that one out. That looks like a very cool CBT strategy that we can add to that list. If we look at information from positive psychology, that's simple things like noticing kindness, doing kind things, checking on an elderly neighbor, savoring small moments of experience and kind of wrapping them up and remembering them, looking at photographs, noticing good things that are happening and having those positive affirmations. Again, patients really enjoy hearing about these things when they're anxious, and these are all strategies that you can try. This is another strategy to clear yourself after you're leaving work, after a tough day, is do some clearing exercises to decrease the impact of that day at work. And I find I actually do these automatically. I didn't realize it was a thing, but I do this. You're looking in the rearview mirror as you drive away, doing some breathing exercises before you start the car, having some rituals when you get in the door can all be really helpful to demark the time at work versus the time at home, so that you can be more present for your friends and your family and yourself. I looked up some tips for healthcare workers and emergency responders, and you can see the sign there, thanks for everything you're doing. There's lots of appreciation out there. Recognizing signs of burnout, if you will, or stress in yourself and in your colleagues, maybe creating a buddy system with people at work just to make sure that everybody's doing okay, managing their workload. Again, we've talked about a lot of these strategies like the breathing, mindfulness, sleep routine, and recognizing that the world isn't all on your shoulders, that it's okay to take breaks, it's okay to monitor your workload, and recognize that you want to make your best contribution. Remember the Physician and Family Support Program. They are there for you. They're just a call away or an email. Good. And also, Dr. Nicholas Mitchell on our AHS website has his mental health moments. So I've been checking those out. He's had one on talking to teenagers. He's had all sorts of really excellent points on those little videos that he's doing. So you might want to check those out as well. In terms of Calgary resources, I'm just going to mention two before I close. The Canadian Mental Health Association also has a email and call support for the patients or clients here in Calgary. And the next one is the Eastside Family Center, and that's a center that I go to every week. We're now closed for walk-in counseling, but they are available for e-therapy, text, and I'm consulting on some of the email therapies that they're doing. So that center is very much has been very much activated by this and is adjusting to the changing times at Eastside Family Center. So there's lots of ideas. Remember, there's hope in this and light at the end of the tunnel. I think those strategies can help you and your patients. And if you remember back to the very first strategy that I talked about, it was getting facts from experts and trusted sources. And Dr. Gill, I'm going to pass this over to you because you are our trusted source. And I know things have evolved a lot in the last couple of weeks since we last heard from you. So over to you.
Thank you. First of all, being a member of the university, I have no relevant disclosures. Now, I completely agree. Life is getting very noisy at the moment with messaging. You turn on the news, you read reputable newspapers, you look at journals, you get emails from your colleagues. There is a lot of noise out there about COVID-19. A lot of papers are being published, and I'm being sent things that actually someone put together something that looked like a paper. They posted it on a website now you can post on that's called a preprint. It's not peer-reviewed. No one's looked at it. It sounds sexy. No one said the science is any good, but it is immediately networked because everyone realizes we're in a tough situation and we'll grasp at straws on any science. So when you hear that you've heard that there's a cure out there, they may have heard it from something that really is not science, it's just propaganda. Another problem when I'm kind of trying to figure out what the real message is here is the science may be correct, but the conclusions overstep the science. The science may be clearly terrible, overstated. I read a paper recently that I reread repeatedly. It's incomprehensible. It's junk. It would never, in a normal world, make peer review, editor's comments, review, readjust to make it good, intelligible, usable science. There's a lot of noise out there. So what I usually do is I go to really good journals like the Annals of Internal Medicine or the New England Journal or Lancet. But you've got to be careful with those as well because sometimes articles are premature, they're a little bit incomplete. They haven't had the benefit of 6 reviewers say that you could improve it like this. Can you do this experiment? Can you do that experiment? Because the bottom line is the authors, the reviewers, and the journals are under pressure to be the fastest and first out with new results. So be very careful. Some junk, some partial, and some good science. So the message is very stressful when you're looking at it. Now the good thing is that the slide I gave a few weeks ago, the diagnostic challenge for you or I when we're seeing someone is really unchanged. COVID-19 presents like a flu-like illness. The big features are still pretty popular in the literature as being the ones to watch out for. Nasty fevers, a cough. Remember, this is not an enterovirus, not an arbovirus, not a bloodborne virus. It's a respiratory virus that loves respiratory mucosa. So when you get symptoms, it's going to probably be in the cough area. Along with a fever, then the response, the body becomes very tired and extreme fatigue is quite common. Other symptoms are still much the same. We really don't think it causes much stomach upset, very rare. And in the last 2 weeks, a new symptom has appeared that I think is actually quite credible. Anosmia, hyposmia, or dysgeusia. And for those of you like me couldn't remember what dysgeusia meant, the virus attacks our upper respiratory tract and it tends to send our sense of smell and taste off base. And now in the ear, nose, throat literature, they're saying, we got referred this patient for loss of smell and actually they've got COVID-19. And that is kind of new since last 2 weeks ago. But still the biggies are fever, cough, myalgia, and fatigue. When we're trying to figure out if someone's has a problem with COVID-19, contact and travel are really important, though I'm sure everyone watches Dr. Hinshaw's community contact where we don't know where the virus came from. So that, again, is something we watch out for. So far, we're lucky Very few of those cases, but it's certainly an area of angst for all of us. So the diagnosis is still the same as 2 weeks ago, a nasopharyngeal swab looking for viral genetic sequences. It is the only test we have. You don't need an N95 to take the sample. You probably should be wearing glasses. And a BAL, a bronchoalveolar lavage, seldom indicated. Oral swabs don't really cut it. Nose swabs don't really cut it. Nasopharyngeal if you want the diagnosis. It's a genetic test. The lab looks for the E gene, and then if they find that, they look for the SARS-CoV-2 special gene, the polymerase gene. Now, as with any test, junk in, junk out. If you take the sample in an asymptomatic and you don't find it, doesn't mean that someone wasn't exposed. If you take a bad sample and it's negative, doesn't mean that they don't have it. And so interpretation is tricky, and you've got to apply common sense. You know, was it a good sample? Was it taken in someone with the appropriate symptoms? And then there's a little bit of interpretation as well after someone's recovered. If you find viral sequences, does it mean they're cured and you're just finding debris left over from the virus, or does it mean they've got active infection? So the test still is molecular on an NP swab. Now, you may notice the number of tests we do is going up and down. Well, there's a global shortage of the reagents and the equipment to do NP swabs. Everyone in the world, every major country is busy cranking up production and buying all the reagents. And this is not, we don't have an oversupply of the reagents to test. That's part of the reason why we don't test asymptomatics. We're at the moment focusing on those that we need to know. Probably the most exciting thing that is on the horizon is serology testing. Wouldn't it be nice to have a regular blood test you could order to tell if someone had been exposed and had had an asymptomatic infection? Our epidemiology colleagues would love this because it would tell us how many people out there were susceptible and how many had had an asymptomatic infection. It would also tell us if we got some healthcare workers who'd been exposed, recovered, who now could carry the burden as we get more and more infected people without worrying about their own personal health excessively. So serology is close. The rumors are that there will be a fingerprint blood test out fairly soon that will be really helpful. There's a question about the sensitivity and specificity. The specificity using the two-stage is extremely good. Sensitivity is, we believe, very good. It is not as good as sticking a bronchoscope down in the lung, but of all the tests we have, we probably think it's up in the 90% range. Dr. Hu may make an adjustment on that comment, but it's pretty good. This is not one where if you've got someone with COVID infection, a cough, fever, you're going to miss it with an NP swab that's properly taken. Okay, natural history, much the same as 2 weeks ago. Still an incubation of about 2 to 14 days, a median of 5 days. A recent study came out and said that 97.5% of people who are exposed and become infected will develop symptoms within 11 days. So when you have someone who said, well, I was on a cruise 3.5 weeks ago, it isn't going to be COVID infection. The big challenge is we don't know how many people are asymptomatic and infected. Probably lowish, but it's like an iceberg. We only test people who have symptoms, so we don't know how many have the infection who don't have symptoms. That figuring out the asymptomatic infections and if they are infectious to others is really important evolving science. We hope the number is relatively small, but we hope as well that they're not infectious. Same as last time, about 80% of people have a self-limited respiratory illness, probably lasts about 14 days and then they get better. Several of my colleagues around North America tell me they felt really crummy for about 14 days, and then they're bouncing back to good health. 20% have more severe illness requiring medical care, with perhaps hospitalization. The hospitalization is mainly about the respiratory tract. And as the infection in some spreads in the respiratory tracts, compromises breathing, they get multi-organ failure due to a cytokine release. Their lungs become plugged, require ventilation to keep the fluid out of the lungs, and a high risk of death. Now, the progression rate down each curve and the time isn't really well understood, but generally we're talking about an asymptomatic or a low-level infection responding in about 14 days. The next question we're asked is, well, how many people with this infection are going to die? And someone's read that 10% of Italians died, but only 0.5% of Koreans died. You know, why is that? Well, one of the main drivers for the people that we need to watch out for is age and comorbidities. Any age is susceptible to die from this infection, but if you're older and you have a truckload of comorbidities, you're far more at risk. So that is one driving factor, and it partially explains the 10% in northern Italy and Lombardy. Another fact that can influence fatality rate, if someone rolls into the emergency very sick, they may be past the stage where ventilation is going to help. The third one that I think probably accounts for some of the astonishingly depressing figures out of Madrid and Italy is healthcare can get overwhelmed if a whole lot of people turn up at the same time with catastrophic illness. And this is the background for flatten the curve out, because we may be able to cope far better if we have 100 people turn up to the emerge over a week as if we have 100 people turn up in the emerge over 1 hour. So flattening the curve is really important because that's what influences the fatality rate. Another uncertainty in establishing the fatality rate is we say, well, in Alberta, I think we had 5 deaths today, maybe 8 so far, and we've had like 700, 600 infections. Some people, we don't have the endpoint yet because they're in hospital, they may be on a ventilator. If they haven't died, we don't know what the endpoint on fatality is yet in Alberta. So that accounts for some of the uncertainty about what the fatality rate is. Hopefully, though, we can keep it into the range of about 2.3% overall and recognize that our patients who are older, who have multiple comorbidities, are at greatest risk. So we have someone in the hospital maybe, or at home a little bit fragile. What do we have for them to offer? Well, the bad news at the moment, we only have good supportive care. Since the last time I talked, a drug that we'd mused about, Kaletra, which is an HIV drug, was tested in a large study out of China and published in the New England Journal that said, despite having some benefit in treating a sister virus that causes SARS, it really isn't very good in COVID-19. The optimists in the review all say, well, if you look at left-handers who are under the age of 19, who have good respiratory status, there was perhaps a statistical signal. But I think it's being overly optimistic. This is going to be a good tool to treat SARS. The next slide I'm going to show after this one is hydroxychloroquine, azithromycin, chloroquine. The value is unclear, but I'll talk about that in a minute. There are over 500 clinical trials listed for treat COVID-19. That is an awful lot of research going on. If you are interested in remdesivir, it looks a very promising drug. Definitive studies are not yet published, but it's extraordinarily difficult to get in Canada, which is disappointing. But it's an American drug developed out of America by an American company, and it may become very difficult to access in Canada while there are many Americans suffering from this infection. For those who like guidelines to follow, which I do, there's a nice set on Alberta Health Services website developed by Dr. Lenora Saxinger in Edmonton, along with the ID group in Calgary and Edmonton, that gives you a kind of template on what's there, what isn't there, what might help. And hopefully it will give you confidence that you don't throw drugs that you've read on a social media might help, because sometimes desperation medicine actually is bad for our patients. As you probably read, President Trump announced that actually there is a potential cure for coronaviruses just around the corner. It's a drug called Plaquenil hydroxychloroquine, and that America was just about to wipe this epidemic out with the use of this drug that he'd heard was really good. That caused major shortages for all the unfortunate people who needed this drug for lupus therapy. It caused shortages for malaria, and according to CNN, some people, due to anxiety about COVID, had already had fatal overdoses from a drug that probably doesn't work. So do no harm in medicine can be very important, and recognize our limitations and our strengths. What's noise that's interesting in the last few weeks? Well, for men in the audience, there is information that men are twice as likely to die as women if you match them by age. Then some non-believers said, well, it's because men smoke more than women. In the original study out of China, out of one country, that was true, but in another, they matched them by smoking. Not true. And probably there is some truth to this in that we men are limited by only having one X chromosome. Ladies have two X, and the genes that carry much of our immunity are on the X chromosome. So maybe having two of them, even though they may not be fully expressed, might be helpful in COVID-19. Just interesting, the science is out there, it's not bogus. You and I can't do anything about it, but it's just interesting. Another thing you might have read about is blood type A seem to be more vulnerable. Science is very weak, but there are some data out there in other diseases that some people are immune to viruses because of their genetic composition. Maybe it's tagged to blood type, but just watch it. It's interesting. I can't change my blood type, but it's an interesting phenomenon. The French Minister of Health a few weeks ago said NSAIDs exacerbate COVID-19 infection. The science isn't there to support that. Everyone's waiting for him to produce the science, but I think he's off on sick leave. So this is tricky. Probably wouldn't change NSAIDs or change them at the moment, but it's something to watch in case there's some truth behind it. I'm asked, is COVID-19 dangerous for if I catch it and I'm pregnant? Well, how could we tell if you catch COVID-19 in your first trimester and the virus has only been around for 3 months, whether it's going to be damaging at 9 months? We can't tell. My personal belief is this is not really a viremic virus. It's probably going to be okay. But I have no science behind that other than a belief that usually the things that cause damage to in utero babies is viremia. Another topic generating incredible angst to my infection prevention colleagues is our test is molecular. We pick up sequences of viral genetic material. Question, does that genetic material mean there's a whole virus there that can infect people? And the answer is, at the moment, we don't really know. Sometimes certainly yes, and sometimes probably no. And that question about viral genetics and live virus is something that comes into a whole lot of questions about transmission of fomites, inanimate objects, etc. And that is something to watch because I think it's interesting. The angiotensin converting enzyme theory rolls on, and in fact, about an hour ago, I got a web page sent to me that stresses this might be important. And the basis for this is that SARS-CoV-2 virus enters by using the ACE2 receptor, which is on epithelial cells, particularly in the lung. When you have ACE2 expression, it's increased in diabetes and in those treated with ACE inhibitors and angiotensin receptor blockers. So the question is, are some people a little bit more vulnerable to this infection than others? Certainly, I think changing therapy is to be a risk-benefit for any physician, and I don't think you should launch into any changes just in case someone's exposed. You should ask them maybe to wash their hands and to socially distance or physically distance as much as possible. Some of my colleagues I know think that calcium channel blockers in a patient where all else is equal might be a better choice than an ACE2 blocker. About 20 years ago, my wife used to love a really slushy thing called The Love Boat that was on television. So I thought I'd give you some remakes of a series are good and some aren't quite as pleasant. So what actually happened with the Diamond Princess cruise? Well, a nice paper came out in the CDC journal MMWR that is the first of a whole series that explored this. And bottom line is there were about 3,700 people on board this cruise ship that took a cruise. It offloaded a chap in Singapore who was immediately diagnosed with COVID-19. And the ship then entered quarantine, and I think it was Yokohama Bay. Well, over the 16 days when it was bobbing around in Yokohama Bay, a series of 3,000 tests were conducted, and 634 persons on that boat were tested positive. Most of them were over 60, but that matched the passenger list, and about half of them were female, which again matched the passenger list. What is intriguing is that only half were symptomatic, and about half, when they were tested, were asymptomatic. Some of the asymptomatics after they were disembarked became symptomatic, but some didn't. And the estimate from this story is that about 18% of the infected cases may be truly asymptomatic throughout their infection. This is the only good data I'm aware of that looks at asymptomatic. Whether the asymptomatics had enough virus to infect other people is unknown. They might have had just a fairly localized benign infection that didn't give them symptoms, but we don't know, but it's certainly an interesting feature. Lots of trials going on, some in Canada. There's the CATGO study, which is a Kaletra study. There's an outpatient early therapy study that hopefully will start soon that compares hydroxychloroquine to placebo. There is a study being looked about for post-exposure prophylaxis for healthcare workers. My ICU colleagues are looking at colchicine or tocilizumab for therapy in really seriously ICU patients with multi-organ failure. All of them are good research, but the results aren't out. Don't guess the research result because the treatments are not necessarily benign. On the good news, first of all, we've been sequencing the virus. It doesn't mutate much, which makes my vaccine colleagues get very excited because some viruses change their construction every few years or every few months and makes them a very tough target for vaccines. COVID, fortunately, doesn't change much, which means it's a better target for a vaccine. The disappointing side of that is that some bacteria kind of mutate out into non-existence, some viruses and bacteria, and they flame out or become less pathogenic. The fact this doesn't change much suggests that that's not going to happen here. So the good news, vaccines may be more possible. Bad news, it's probably won't peter out on us for no apparent reason. There's some beautiful science coming out on using phylogenetics because the virus changes a bit. So now we can track where the virus in Iceland came from. Did it come from China or did it come from Europe to Iceland? And there's a beautiful website that's I can actually post with this that you can play with. It's interactive data and you can see how the virus is tracking around the world. Another encouraging bit of news is these, as I said, these antibodies are close. The antibody test, very useful for determining natural history in health, also figuring out who's infected, who hasn't been infected for healthcare. So I've given you a lot of information, and my last slide is one that my parents were well familiar with in September of 1939 when World War II was described. I'd suggest you keep calm, as Margie said, and carry on. Thank you. Over to you, Rick.
Thanks. And when you've got the infectious disease experts giving cognitive behavioral therapy advice and those positive affirmations, you know you've got a great team up here. And speaking of a great team, I really want to give a shout out to Jia and to Christine Kennedy, who have been frantically answering questions in the chat line. Thank you so much for doing that. I'm here to put in a couple of minutes filler while we change the technology. Jia Hu is our medical officer of health who is self-isolating, but through the wonders of modern technology, we're going to Skype him in. He's going to give the public health MOH perspective on what's happening. As I'm spending some time here, I also want to just answer a couple of the questions that have come up. One of them is, I want to be able to sign in to help, but do I contact the CPSA? John Meddings sent a note out asking for volunteers. I think there's many portals that will allow people the opportunity to give their service and be involved as things progress. Christine, I'm also aware that all of the PCN medical directors and PCN offices also are keeping a registry of people who have volunteered to do more during this time. Can you maybe speak to that briefly?
For sure, Rick. What we're trying to do is actually keep track of physician and other team members in our medical homes and by PCN. So each of the PCNs should be reaching out pretty much on a weekly basis to find out if you're still in operation. Are you open for face-to-face? Are you open just for virtual? Part of that's around reordering of your personal protective equipment as well. So we're trying to keep a pulse kind of on what our workforce looks like just for primary care, just to continue to deliver that. But then that's also an opportunity to say that you're interested in helping out wherever needed. So as we continue to plan and move forward to our next stages, that you'll be able to put your brains to good use.
Thanks, Christine. There's also a number of questions online about are they going to designate one hospital for people who have COVID? How are they going to deal with the manpower crisis? What I want to reassure you is that every day, sometimes it feels like every hour, there are meetings at high level for people that are looking at all these contingencies. We don't have the time, and nor is it appropriate for us to talk about what's going on behind the curtain, but be assured that primary care has a strong voice in all those discussions. We hope to use this format as a way of giving you just-in-time information about things that change, hence the increased frequency of these. Depend on your PCN newsletter as a secondary source of information, and we should be here once a week to be able to augment that information. So I understand that the technology has now been set. I want to invite Dr. Jia Hu to join us and run through some slides, including addressing some of the frequently asked questions that have come up through the PCN group.
Hi everyone, it's Jia Hu here. As Rick mentioned, I am on self-isolation. I started feeling like a mild headache and a bit of a rhinorrhea while I was at work today, and so it went really fast. And I'm really bad at social distancing, just intrinsically, but I think, you guys should do the same. Even if you feel the mildest symptoms, you should go home because it's, better safe than sorry. It's particularly important, I think, because, as you may have seen in the news, we what is informally called the Med-Student Army, or what is now called the Alberta Coronavirus COVID-19 Exposure Response Team, is based at the Shell in Shumir and is now doing 70% of the case and contact follow-up province, communal disease program, which is also really awesome, but I don't want to knock them out. Oh, you look skeptical. You still hear me? Yeah, I think so. Okay, just nod. Okay, sweet. All right. First slide is just a little graph that shows where Alberta is doing vis-a-vis the rest of Canada. I think people have, the number of cases have gone down recently. Some people are saying, is this a good thing? Have we bent the curve? Have we planked the curve, as it were? That's the latest thing. I think it's too early to tell. We're running fewer tests than we were before, but it's not a precipitous drop off, but it is lower. I wouldn't actually expect to see any, when we do a test today, it reflects infection from at least 10 to 14, about 10 days ago at least. If you think about the incubation period, plus the 5-day incubation, plus let's say 2 days before you're like, oh, maybe I should get tested, plus the turnaround time for the testing. So we won't see things for a while, but that's okay. So that's that. Quick overview of what we're seeing in Alberta. 660 cases as of this morning. That may be an update. 2/3 in Calgary. 41 hospitalized, 14 ICU, 5 deaths as per Dr. Hinshaw's report this afternoon. We have a few clusters, a prayer group here, a medical bond deal in Edmonton that made the news, and some long-term cares as well. So got to be really careful about the long-term cares. I think it's just 1,000 tests done roughly to date. We're up to 3,000 plus a day, but now we're down to maybe around 2,000 a day. As people may have seen in the news today, I don't know when it came out, provincial government acquired a bunch of tests through this company called Spartan. Those tests are like real-time PCRs. I think they plan to ramp to like 30,000 or something in 6 weeks or something like that, which is really good. So that's an example of how we're trying to really increase our testing. It's a super, super high priority. So here's the way I view coronavirus. This is slide 3, 5 problems to solve, if we advance to that one. I think there's 5 things we need to do, basically, to really solve the problem. So one is increase lab testing. I put that like as yellow, but now that we have this announcement, I might move to green. We're still not testing as many people as we want to be testing, okay? But like we have a plan to ramp up. Number 2 is to do case and contact follow-up for all confirmed cases. This is where we call you if you're a case, tell you to stay home, and then call all your contacts that you've been in contact with. It's about 20 contacts per case, so it is a bit labor intensive. But with the sort of ACER med student army model, we quadrupled, not tuple our provincial capacity really fast, like in 14 days. And, we're trying to get other provinces to hop on board as well, which I really like. Number 3 is, effective self-isolation and quarantine, plus one in red is because we just don't know if we're any good at this, right? So recently, Dr. Hinshaw government announced some fines for people who break self-isolation, but I think currently we don't know if people who are cases stay isolated, right? We don't monitor these people in any way, and other countries that have been successful have done things like in China and South Korea, put them in quarantine centers, and in other countries like Singapore, put them, done some location tracking app thing that where if you leave quarantine, you get, pinged essentially. The same applies to social distancing. I think when I leave my home, I see fewer people on the street, but I don't know what the decreased density actually is. And again, we're not like China. We can't do what they do. I mean, they've been under a real lockdown for a while now. And by real, I mean, I think it's really enforced. Whereas places like Toronto have been they're technically on lockdown now, but I don't know how, a lot of stuff is open still. The other big piece to this actually that I think is really important for family docs and primary care providers to know is the city has, when it comes to people staying on self-isolation, it's we want to support them as much as possible. Has basically, has basically, put together a bunch of resources to help people stay on self-isolation. And at a very high level, if you have any questions about that, have people call 211. That's have your patients call 211, and they've like assembled a bunch of services. And there's also this like YYC Facebook group for COVID that I think there's 15,000 people on that. And so if people need help, then you can, have them ask on the Facebook group. The other day, I was dealing with a case, and the guy said he needed money, so I just gave him $100 on e-transfer. But I think we got to support people in self-isolation, basically. So that's that. It's red, I think, until we know. We'll see if we get there. Now, in terms of our health systems measures, so the first three are public health things that prevent further cases from happening by preventing disease spread. Under the health system side, we're also doing a lot of work. So there we need to have enough stuff, and that's like PPE and ventilators and whatever other stuff we need, but people talk about those two things. And AHS says we have enough stuff, so that's a good thing. I mean, I think when we think about whether or not we have enough stuff, like I hear about what's happening in Italy and New York, and I get a little bit worried. And it is hard to predict sometimes how much stuff we have or how much stuff we'll need. But I say that because there's a certain burn rate that we have to sort of model for, and that can change based on, things about the disease as they evolve. But, I know we're working really hard to get more stuff, including working with the University of Calgary to locally produce stuff, and then manufacture it locally. So that's really good, I think. And people are building ventilators in the garages. And all in all, I think we're pretty well prepared still. But I'll put that in yellow because I don't actually know how much stuff we have, personally. It doesn't mean that other people don't know, it's just I don't know. And then the last is to increase hospital capacity. And I think there's a really wonderful team in Calgary. A bunch of internists there are they have these wild plans to increase hospital capacity. And it looks really optimistic in terms of it's really cool. So, there was a presentation on this last Friday, I think, and apparently it was very inspirational. Excited about to work in the hospitals, but we appear to be doing pretty well on that front. So those are the 5 problems to solve. Next up is our strategy, and this is where I sort of get to my, again, we talked about this containment, 3 pillars. We need really good lab capacity. We need our testing to be very accessible, high turnaround time too, and we need to do case and contact follow-up for every single case. So this is all containment. We never stop containing. We always contain and we mitigate. Because containing, giving up on testing is sort of like giving up. And I think what's good is that more and more people recognize this is the case, and people are less likely to give up as they recognize that, even though it takes more resources. As a society, we're getting better at mobilizing, which is really good. I said it's easy to get over this strategy. I don't think people are necessarily used to ramping in emergency settings. We've never had something like this before. But the consequences of a failure are very dire. There's nothing. This is the greatest crisis the world has faced in decades. It's not and it's a healthcare one. So it's New York. The 0.3% infection rate, that's pretty low. Italy, 0.2% infection rate, and then modelers saying 30 to 70% infection rate. So that would be very disastrous. All right, and we don't want that to happen, which is why we have to keep trying with containment. My consequence, I was reading an article today saying half of Canadians face insolvency right now. Western Canada Select. Are you texting? No, we're good. Okay. Are we okay? Every time you look skeptical, Keith, I get worried. Okay, Western Canada Select, that's the oil that we make in Alberta, less than $5 a barrel. Okay, that's really bad for our economy. Trillions lost from equity markets, and we will definitively see double-digit unemployment, according to the experts, pretty soon, right? So, if we don't do this right, a lot of people are going to die, and our economy is going to be totally screwed for a long time, and that's really bad. And just so people know, the better we are at testing and case and contact, the less social distancing we actually need. And so I think the model would be a place like Singapore, where they've like mostly contained the number of cases pretty well, and they don't have like full-blown lockdown like China has. So they can actually have an economy. People can have jobs, and people don't all go on EI. So that's just something to keep in mind. So that sort of like ends and so I guess that's sort of where I'll stop and take a pause and just say, as frontline healthcare workers, like you are like at the core of the response, and it can be sort of scary dealing with coronavirus. And you get worried about your own health, the health of your family, the health of your patients. But like this is what you were trained to do, and I know you guys are going to be super good at it and do a really good job. But if I were to say one last thing about this is that where I make the pitch, I am currently trying to get like all sectors of society to pull together, right? So that includes private industry, academia, everybody. And so if you know people who want to help, you should let us know, and we can plug them in some way. If all it is to give some money to the Calgary Health Trust, which is doing a lot of sort of the fundraising for coronavirus, and it's bad for me to ask for money from doctors and others right now in the midst of these like mega cuts from the UCP. But even so, I think if you know people, tell them to get engaged, because we need everybody on board to help. All right, so that ends the high-level overview part. On to FAQs, I guess. Good? Are we good? All right, so I was told these were compiled questions. So what happens if the staff or patient gets coronavirus? So, every time we'll do a risk assessment. In general, there aren't many concerns if the person was not at work while symptomatic. If they were symptomatic at work, though, and I hope that doesn't happen, because I think in general, at least for the staff, you got to tell them if you feel like a whiff of illness, go home immediately. Then we'll basically, find out who the sick person was in contact with, and call them up and tell them to, self-isolate and get tested if they develop symptoms. I think last time there were a lot of questions around practice closure. We're almost never going to recommend practice closure, essentially, right? We might say, maybe shut down as we figure stuff out, do it clean. We're not going to say close your practice. That's not what we do. So that's the staff question. With respect to who do we swab, so I know on the 23rd there were some changes in the swabbing guidelines with a focus on sort of high-risk populations, healthcare workers, long-term care, hospital setting, high-risk people. But these are a bit vague, I think, and they do allow for leeway. If they really wanted to restrict testing, they would make it so MOHs or lab had to approve testing, which they didn't. And I think the main reason this happened was there was a temporary decrease in lab capacity, and that's expected. This is happening across the world because of shortages in reagents, mostly. But, as I mentioned before, we're going to ramp up pretty soon again. So I think at the end of the day, when it comes to who to test, yes, test the people there. But if you happen to know about, I guess public health to know about this, you've obviously say a high risk contact in the case, in many ways, we'll deal with the testing. People not to swab generally are like random people with coughs and colds, in your office right now, unless they have some reason to be swabbed. In the ideal end state, I would want to swab them, but we don't have the lab supplies today right now. So I hope that answers your questions, but I suspect there'll be more. I wish I was on the YouTube so I could see people's typed questions. Should go back on that. Do we need N95s? No, only if aerosol generating medical procedures. COVID-19 not believed to be airborne, so that's that. Okay, so that's it. What about asymptomatic transmission? I'm going to say the current line is that we don't believe there's a huge amount of asymptomatic transmission based on the China WHO report. As John Gill was alluding to, there's a lot of these preprint studies coming out that are talking a bit about maybe more asymptomatic transmission. I think what we've seen in other hospitals across the country is, well, I'm sure you've seen this, at St. Mike's in Vancouver. One more, you're right. That they're now recommending sort of PPE use at all healthcare visits, say in the Emerge, for all visits, right? And I think that's based on like this maybe emerging evidence maybe around asymptomatic or pre-symptomatic transmission, though I can't say for sure because I don't know why they did that because I didn't ask them. But I know that this is sort of being talked about within AHS as well. So that's just something to think about, and I bet there'll be lots of questions about that. But there is not currently any definitive evidence out there saying that like, oh yeah, like, you know, asymptomatic transmission accounts for like X% of total transmission, apart from the fact that we think it's currently still pretty low. Okay, FAQ some more. Should we test in the office? Ideally not. We want people to go to the assessment centers if possible. But if your patient is already in the office and you can do an NP swab and he is available, then you might as well test them, I think. Or I'll talk about the swab thing because people had questions about the swabs, like the nasal swabs, throat swabs, the NP swabs. Right, you know, we're doing a validation study right now with like the NP swab versus all other types of swabs to see what works well and what works, like what doesn't work as well. Based on an N of 20, it seems nasal swabs don't work as well, but we're ramping our numbers up to get a few more swabs into that. And when those are available, we'll have some more idea, like recommendations around, you know, like what the best way to swab is. But for now, NP is a gold standard. How long will this last? I think if you look at the modeling from like January, when this whole thing started, it's evolved a little bit. You know, I don't think the modeling has changed necessarily in terms of like how many people will get infected, but in terms of like the peak, they're saying like it was like, oh, maybe like April or May. And now people are saying maybe it'll be peak in June. And I think the difficulty in predicting the peak is that like it depends on how good our control measures are. And it's really hard to know how good our control measures are going to be because, well, A, we don't necessarily know how good some control measures, like we know that if you like put everybody in full lockdown, like China styles, like real full lockdown, that works pretty well. But it's really hard for countries other than China to do that. And so, for example, let's use the US as an example. You know, when Donald Trump says one day that we're going to like restart the economy in April, and then the next day he says, oh no, we need to put a quarantine on New York. Like, if those things translate into action, those will affect your effective or not, because it'll affect your control measures, and so it is hard to predict. I mean, ultimately, based on what we know about the virus, I don't think this will end until we have immunity. Right, and that's sort of where the modelers are coming from, saying, you know, 30-50% of the people will be infected. Like, you have herd, like some degree of herd immunity at that point. I mean, maybe something magical will happen, and the virus will disappear in the summer. Like, so that's, I mean, that might be magical thinking on my part. So I don't really necessarily, I don't believe that or hang my hat on that. But you know, it's vaccine or infection, right? And I don't think we're gonna let it happen through infection. So vaccine is not going to be around for maybe 12 to 18 months in a best case scenario. So we'll have to be vigilant until then. I mean, I think like what like demonstrably has happened is countries have been able, like China, to reduce community transmission to zero. Now they're lifting their lockdowns, and we'll see what happens then. So I think, you know, people talk about like wave 1, wave 2, and wave 3 in different waves. We might see all of that. I mean, I think the ideal state in the pre-vaccine sort of era of this is a situation where we like maybe get close to limiting transmission in the community, and then we restart, so to speak, we reset the COVID clock and behave like Singapore, where we have like just hyper-aggressive testing and case and contact follow-up, and don't have to do such aggressive social distancing. And that means that like people are gonna have jobs, which is really important. And you know what, I think somebody asked like what impact this thing will have, and it depends on, you know, how well we control it. And I will say Alberta is still top in the country, which it was really good, and we're gonna keep it that way. So yeah, that's me. That's it. Let's take your questions.
Thanks very much, Jia. We promised you up-to-date information, and we also mentioned that there's a strong class of 85
Ooh, I can't hear
UFC
him.
Wombats
I better go on to YouTube again.
connection here with Margie and me. I sent an email to Todd Anderson about the ACE inhibitor ARB question, and Todd's answer this week was the same as it was last week, is that we should not make any changes in our management on patients with ACEs and ARBs, given the evidence that we know right now. So a shout out to Todd Anderson for monitoring his emails on a snowy Monday night. Keeping with the obsessive compulsive disorder theme, I'm going to move a question, first question over to Margie Oakander. Margie, RW types in, I've been spending the last 3 years getting my patients off benzodiazepines, and in the last week I've been putting them all on benzodiazepines. Should I feel guilty? Signed, Rick. I mean, in general.
Oh boy, that's a toughie. I mean, I think our patients that have had immediate success with their anxiety using a benzodiazepine are naturally going to want to revert back to that now with the heightened anxiety. I think if we can talk to them about those other ideas, all the stuff, give them the websites, work with them and try to avoid the use of benzodiazepines if we can, that's obviously preferable. That being said, there's some patients where short prescription, time limited, all of those factors is going to be a fact of life right now. But I think limiting and using other resources as much as possible and really supporting them through phone conversations and all that, I think is the best approach, and really try to limit the benzos over this period, because we don't know how long this is going to last. And it's, as we know, that dependency psychological builds up very quickly along with the physical.
John, who's here live, a question about encephalitis and COVID-19. Is that a common comorbidity?
Not that I'm aware of. I've seen a little bit of data on heart damage, kidney damage, but usually it's within the context of someone who's got multi-organ failure.
Great. And a question to our PCN connection. We've had some people online that have been concerned about the supply of PPEs and wondered whether that was something that the PCN, what's the supply like? Where are we with that?
That's a great question, and certainly part of our ongoing planning is around making sure that folks who need PPE for the care they're delivering in the medical home or in their PCN clinics have it, and that's why we're talking a lot about appropriate use of PPE. We don't want to be wasting this really great resource, so we want to make sure that people are using it properly, and the other piece is making sure they're using it properly so that they don't actually put themselves at increased risk by doing it wrong and thinking they're protected. So we definitely have a weekly schedule for reordering for PCN clinics. So you can reach out if you don't belong to a PCN. Then you can reach out to Lorraine Buchholz at Calgary Foothills PCN, who's for family physicians in the Calgary zone who don't belong to a PCN. And if you are in an AHS facility or AHS-run clinic, then that would be directly through AHS. And we understand right now the stockpiles are holding. We haven't heard that there's a shortage at this point. And there's obviously lots of really smart logistics people working on that moving forward.
Thanks, Jia. I've got you on speakerphone here, and I'm going to get you to mute your computer at home. So the question, just to repeat, that came through is are we approaching a time when there's so much COVID circulating in the population that it would be best if all of us wore masks?
All right, so the question is, should we ever wear masks in the community if there's, a lot of coronavirus circulating? I mean, you gotta believe, so... you would need a lot of it circulating around in a very high density to believe that to be the case, I think. I mean, if we think about why masks conceptually makes sense in a healthcare setting is because there's like a high viral burden floating around you and the patient when you're in a room. For that density of viral particle to exist, like in like, you know, what's a good place to pick? Like Nose Hill Park or something would be pretty insane, I think. So I think we're pretty far from that. I see more. I see more stuff on the internet, you know, around Asian countries wearing masks. Culturally, that's what happens, and there being a better ability to control coronavirus. Now, I don't know if that's causation or correlation. I think that's more correlation. And so, no, I don't think there's really a need for a long time, but I'd want to study a little bit about sort of like average viral particle density in the general outdoors before making that recommendation.
I'm going to turn things over to Dr. Gill for another very clinically oriented question.
Great.
I have one of my patients who has an acute exacerbation of COPD. I've assessed them over the phone. I'm worried that this may actually be COVID. What do I do?
I think most clinicians could distinguish an exacerbation of COPD and COVID from the point of view of fevers and a change in nastiness, consistency of the cough, lack of productivity that's unusual, it's usually a very dry cough, and the extreme malaise and fatigue that is common, even in the benign forms. So I think you go with your clinical judgment, especially in primary care. You often know your patients quite well. Does this feel like the same thing? Or is it something that the patient says, this is far worse than I've ever had before, that would be, to me, a trigger that they needed testing?
Very good. And also, again, from a clinical standpoint, there was some comments that should we be having our patients get O2 sat monitors and using those as a way of keeping an eye on their clinical status?
I think in Calgary at the moment that would be a bit of an overkill. Certainly having an ability to measure O2 sats in your office might not be unreasonable.
Christine, there's a question about what offices should be doing to monitor patients or screen patients who are being brought in for other care. Should we be doing a questionnaire with them? Should we be standing at the front door with a thermometer? What's the protocol that you would recommend?
Yeah, that's a good question. In my clinic and what I've been recommending to docs in the South Calgary PCN that I've been talking with, we've taken the approach of really using our staff that know the patients really, really well and having them screen the patients over the phone with regards to any symptoms, screen the patients by careful signage at the front door. And I'll just take a moment to discuss careful signage because I've been to some clinics recently where there are so many signs on the front door that no one's paying attention to any of them. So in my clinic, we've taken the approach of removing all the signage from the front door except for one triple page sign that is in fluorescent color, and it explains what we're looking for, and it also explains to patients what the risk of them not following that direction is. We're telling them we still want to take care of you, we're still going to help you with that, but failure to comply with this may mean the clinic needs to close for a couple of days, may mean that your provider is going to need to be away for 2 weeks. So we're hoping that social contract helps a little bit, especially with patients that have been on our panel for a long time. We screen them again when they come to the front desk. So our lead MOA has kind of a glass screen in front of her. And so she's asking them again when they arrive in the office. And then we're asking them again when we room them. So we as a team within our clinic have taken the approach, most of us wear glasses anyways. We've all been wearing a mask that we keep on for the whole day. And what we're doing is we're doing that for two reasons. One is to remind ourselves to keep our hands off our face. And the second reason is I would feel horrible if I saw patients and then, in the next hour, all of a sudden started to feel feverish, etc. So we're doing it more as a physical reminder. So, and I'm not sure, and Dr. Gill could maybe weigh in if that's just offside. But we're making sure to tell patients that we can do a lot of what we do in family practice over the phone, reverting to those first principles that if you don't know what's going on with your patient after talking to them, the exam's confirmatory rather than the part we should be leaning on. And I think this is, to take a page out of Dr. Oakander's talk, the positive part of this COVID crisis, maybe to remind us our first principles about family practice and care in general.
I'd reinforce that, Christine, and I smile that showing up in my secure BrightSquid email box one day was a picture of my patient's thrombosed hemorrhoids, where I was able to make that diagnosis through my BrightSquid. We're at the point of the technology where I could do anything about that, but was certainly able to make the diagnosis. John, several questions. Sorry, about what...
I can't beat that.
Several questions about those patients who are on immunosuppressants, and do they need to take extra precautions? If they do develop ILI symptoms, should they do anything with their DMARS or their methotrexate?
No data out there. I think common sense, they need to physically distance and wash their hands a lot. Certainly, if anyone acquires a viral infection when they're immune compromised, it's nastier. And I think of cytomegalovirus, herpes virus, all of which can be quite nasty in face of poor immunity. It depends on the context of how bad their immunity is. If I was their physician, I think it means that you need to watch them far more closely and have a higher level of suspicion for sending them to hospital.
Good. There's several questions about the Roth score and how we monitor patients who are COVID positive or COVID suspect remotely. John, can you speak to the Roth score? If not, then I know Christine can speak to it.
I'll leave it to Christine.
Sure. So I think the Roth score, as well as there's another video that's been circulating where you ask the patient to count to 30 as quickly as they can in their first language. If you're healthy, you should be able to do that without any problems. And if you can't make it through those numbers, then there's different cut points, and we can add that link, I think, in the FAQs. But the idea is that would give you a little bit of a sense around their oxygen saturation being below the 94% number that's been thrown around as being, maybe that red flag. Obviously, looking for things like cyanosis, looking for work of breathing and other things. If you're able to do video conferencing, is also very helpful and probably one of the best reasons to go onto video conferencing, not just telephone calls, as we're doing virtual care. Is that an adequate answer for you, Rick?
Yeah, no, I think it is an adequate answer, and I'll just reinforce, we will send the link to a good YouTube on the Roth score. I'm working with infectious disease, general internal medicine, and pulmonary on a pathway that will be available for primary care physicians for home ambulatory assessment of patients who are at home recovering from COVID disease. And we did look at the Roth score, incorporating that, and decided against it. And that was based on another excellent article, the link of which we'll send out to you. If you're anxious and want to get to it first, Google BMJ COVID ambulatory monitoring. That's an article that came out 5 or 6 days ago in BMJ, and we're using it as the template for what we're going to be giving as a primary care pathway. So what this does is it speaks to how to best monitor people at home. We will include the Roth score. I think it was Christine on here had mentioned on the chat that she's used it twice. I've used it once as well and found it actually to be a reassuring adjunct. So a couple of tools that you can take away tonight in terms of home monitoring. Back to some questions that came up, and maybe I'll start off with John, but this might be a question for Jia. People have heard that using the chlamydia swabs, the STI swabs, if they don't have NP swabs, is a suitable substitute if they run out of NP swabs. Do you have any comment on that?
I'll let Jar answer. The trouble is when you start using the wrong swabs or adjusted transport media, you may lose sensitivity. So I'll see what Jar has to think about that. Clearly, we want the right swab.
Okay, here he is.
Yeah, no, I would not do that. The lab may do that under like sort of controlled settings, so to speak. But if you need swabs, I wouldn't use STI swabs. This is why we're doing the whole validation thing. We're looking at like different types of swabs being collected in different areas. So I would not do that in the office. And if you need NP swabs, the lab may be able to give you some. And if you really are, and they can't, then send the patient to an assessment center.
Just accurately there, have the patient do the self-assessment and call 811 for an appointment at an assessment center. Do not just show up at an assessment center.
Margie, I'm going to turn over to you, and I wonder if you could, and I know you touched on it in your talk, but I wonder if you could just highlight some of the other resources that patients might be able to use out there if they don't have resources and access to that.
I think in terms of resources, certainly that text program through AHS, the number that I gave out earlier, provides people with ongoing CBT. Now that's through the text program. Eastside Family Center, again, their e-therapy and their chat therapy, I think, is a nice substitute for the walk-in service. So I would suggest that as a good resource. Calling 211 also is providing people with a lot of resources. And a lot of the agencies have adapted their normal procedures to using phone therapy. So Canadian Mental Health Services as well has adapted that to phone therapy. I think, the family physician is always an important resource for support. And I think the more that people can reach out to their primary care provider, that's really, really important. And using the community resources. I think the websites, fan those websites out that I included in the slide deck for resourcing for your patients. And I think it's, again, it's time to really help them build on that resiliency as they feel the anxiety, feel the fear, and try to cope with that in all the ways that I outlined. But those community resources are available, and they're waiting for people to call, text, and email. And you can get some good support through those modalities here in Calgary. There are a lot of resources that are up and running. They've just changed with this pandemic. They've changed the way they're delivering service, just like we all are. In terms of our clinic, for example, at Sunridge, we're creating more space for assessments through the emergency room. So we're anticipating emergency may become very, very busy. So we're providing more emergency support. And I think many of the hospital-based clinics as well are going to be doing that for our patients that are in the most distress, to take some of the weight off of the emergency rooms.
Good, thanks, Margie.
Rick, and maybe I'll just chime in as well, just as a reminder, yesterday the government announced increased funding for Kids Help Phone, as well as for United Way for programs for services within mental health, and especially for seniors who are at home and already struggle with frailty and loneliness. And Connect Teen is another great resources for teenagers, which allows for text and chat room conversations around mental health disorders.
Thanks, Christine. Margie. John, another question for you. Could you clarify that there was a reports on the chat line that they're using nasal swabs in some of the assessment clinics, but NP swabs are what we understand to be recommended. So if you could just maybe explain or help us square those two corners.
Yeah, totally. So we've heard from some of the assessment centers that people are like not going so deep. So there's like different types of swabs. There's like your classic NP swab that's like a little bit bendy. so like it can go down your nose a bit better. And I've heard there's some like more rigid swabs that aren't supposed to, you can't jab them down the way you jab an NP swab down. So 2 types of swabs. And lastly, like sometimes people haven't been like using the swabs appropriately in that they maybe just do like a little gentle nasal swab. And so essentially we heard about this happening, and today an APL bulletin came out that basically and telling all the assessment centers that whatever swab you use, you gotta like get deep into the nasopharynx. So we've hopefully addressed that concern.
Good. So keeping on the public health theme, a question in the chat room that we're relying so much on the flow of materials north and south across the border. Patients who are truck drivers and are transporting goods across the border, do they need to isolate when they come back?
Yeah, I think there's like some exceptions to certain populations, and I think there's an exception. They're an exception, right? I think when the borders were closed between the U.S. and Canada, they didn't were largely closed. They didn't close them to all types of traffic, and the same applies to pilots actually. So pilots flying transcon, there's not a whole lot of flights anymore, but there are still flights. So they'd be another population that's sort of exempt from the normal rules.
Great. And Margie, a caller a poster who has asked about alcohol use disorder, a patient with alcohol use disorder who's destabilizing at home. Are there specific resources for folks with addictions who are relapsing right now?
Yeah. As a matter of fact, As a matter of fact, one of the mental health videos that was on the AHS site actually talked about our patients with addiction issues, and I think that's a good thing to have a look at. Many of the AA networks are doing things virtually, so I think those patients that may be connected with an AA group or their sponsor, this is a time where they really need to be using those community resources, maybe through a virtual format, and as well talking to their primary care provider around if they are using again, how do we help them with those addiction issues, depending on what it is. But I think keeping their support community intact is really important, especially if they're relapsing.
Yeah, thanks, Margie. And a patient of mine this morning who has alcohol use disorder was saying that her AA group has gone to a virtual format. So I think that a lot of those community programs are making that pivot. John, there's a question about atypical presentations, and the question was around atypical presentations in the elderly. But I think I'm going to expand the question to say, are there atypical presentations that we should keep in the back of our minds to say, if you see this, just think?
Virtually any medical problem in the upper respiratory tract could make us think. It's all described. The big three, I talked about the cough, the fever, the myalgias, the fatigue. But the last 10 days, the poor sensation on smelling and taste is new. So I think anything in the respiratory tract, upper respiratory tract or lower that feels unusual, in 2020 in March or April, we should start thinking about. Runny nose, very, 1%, sneezing, very rare, but you need to think about it, and certainly it should trigger, you could say you should isolate for a couple of days and see if your cold goes away. If it goes away, great, it was a cold. If it continues and takes unusual characteristics, off to an assessment screening center.
Great, thanks. So Jia, another question, self-serving. A physician who would be in the high-risk category has a wife sometime returning from India. She will, as we know, self-isolate for 14 days. Does that poor lonely physician have to sleep on the couch, or should he get a room at the Y?
Oh yeah, okay, this is a good question. So no, in general, partners do not have to leave home. partners don't have to self-isolate if they weren't the ones who are sort of exposed or have the exposure risk, right? So the same applies if you're the contact of a case. You have to self-isolate, but it doesn't mean your kids and your wife or husband or whatever have to. Now, with respect to sort of like, does the partner have to leave the house? I think that sort of speaks to the larger question of like, what exactly is self-isolation? Now, today, as per Dina's press conference, there's been sort of consensus around Canada that before people on self-isolation could go for walks, apparently, but now they can't. You got to stay on your own property. And the way I like to think about self-isolation is the ideal end state of self-isolation is like one where you don't see anybody, including your family. Now, okay, think of that as like sort of difficult for many people, but really, if you were a case, you would probably not want to see your family if at all possible. And so, if possible, if your family could leave the home you live in, that would be good. Short of that, which is not possible for everybody, you sort of want to, live in a different room, stay in a different room, use different bathrooms, get your own food, and just try to see your family or whoever you live with as little as possible. We know that there's obviously different amounts of risk depending on why you're self-isolating, right? There's somebody who's a case obviously is at the highest risk of transmitting versus somebody who's self-isolating because they're the contact of the case, which is slightly higher risk than somebody who's self-isolating because of return to travel, which is lower risk than that. And so, I think in the public messaging, it's hard to like say things like try not to see your family and self-isolating. But you guys know the risk. You can risk stratify in your heads. We're all healthcare providers. And so like the line should be, you should really try not to see the people in your house, I would say. Like physically, you can use Zoom and stuff and all that. Does that make sense?
Regrettably, yes. Hold on. This is, I think, is a two-part question to John and you, Jia. And I'm going to start with you on the phone. So, still lots of questions about: is it wrong for patients who want to use masks? Is there any when they're out in the public? Is there any evidence for homemade masks being effective?
Oh, yeah. I mean, I think if patients have, masks, they should, give them to AHS, frankly. So, honestly, be like, hey, no, I'm serious. So, is it wrong? No. Is it going to, in general, early on in this sort of outbreak, people were saying, masks, wearing masks in public, in general, could be at higher risk because, you might auto-inoculate or something. Whatever. There's no evidence really that wearing masks in public does good or bad, so it's sort of like a hypothetical argument, yay or nay. But I think that they don't need to wear them in public right now. Now, cloth masks or homemade masks, and people make masks out of all sorts of things, it's an interesting one because the US CDC has now come out with this sort of wear your bandana recommendation, I think. And their thinking with that is that it is better to have something than nothing. There's not a whole lot of evidence for this. I think there's pretty good evidence that a cloth mask is inferior to a regular surgical mask that you place. And there's some sort of studies that look at how much stuff these little masks filter that show that they do filter through some things, but a lot of it's going to depend on the material you use, and so I don't think right now people should go around hospitals wearing little cloth bandanas or something, to be honest. I think it merits further study potentially, but it's going to matter a lot in the material of the mask, to be honest. So we'd have to have some sort of standardized material. I do know a lot of people in the city are actually weaving masks, and I think that's kind of cool. It's a type of community mobilization. But before recommending on mass scale use of those cloth masks, I will certainly want some more evidence that they were good.
Good, John.
First of all, they need to be covering the nose. It amazes me, 10% of people I see have got the mask covering their mouth underneath the nose. It kind of defeats the purpose. Second thing, as a virologist, I think viruses are being really small, and across a cloth mask, the virus goes straight through it. But there may be value if you're wearing a mask, you don't touch your face as much, and so there is a kind of secondary value to that.
Christine.
I'm going to actually put a question over to the guys, if I may, which is, so healthcare workers working in ICU, emergency room, hot zones, or even as we move forward in primary care and we're caring for more COVID patients in the community, if we are wearing our proper full PPE, so shield, mask, gown, gloves, and we're donning and doffing properly, do we need to take any precautions when we go home to live with our family?
Well, I don't think so. First of all, I think of a virus, it does not multiply outside the body. As soon as it leaves the body, it's in a death spiral. And there is evidence that on most surfaces it's gone, at least the genetic signal's gone after 4 hours, perhaps up to 24 hours. So, I walk out of my clinic on a Friday night. If no one's in there till Monday, every virus in that COVID virus in that clinic is going to be dead. Absolutely certain. I don't need to worry about disinfecting it from the viral point of view. They don't survive well outside the human body. When I go home, I usually take off my gloves and I go wash my hands as very first thing. And then I make sure I don't touch what was on the outside. And I don't generally tend to get spattered on my clothes. If I think I do, I think washing them's fine. I know some of my colleagues are moving into surgical scrubs in the hospital, which isn't a bad idea. But it depends on how much splatter you're going to get, because touch on your clothes probably is not a risk. A good respiratory secretion on your clothes, I'd want to wash it.
Several questions. Rachel and JM asking about the duration of wearing a mask. So should you decide to wear a mask for safety, how long before you should remove that mask? And also, if it gets wet, does that take away the efficacy?
Yeah, sure. So right now in the assessment centers, we're having people keep masks on for until they get wet or humid, which degrades the mask a little bit, or for like about half an hour. But I will ask the IPNC folks right now what they think. So I will CC you as well, Rick, and then you can share the answers. How's that?
We've got our scribes, Rachel and Oliver David, our two medical directors from Calgary West Central and Mosaic, who are madly collecting these questions, and will follow up with answers. There was a question about groceries, and I think John Gill had a slide that he didn't get to that says, should I be washing my coconut before I consume
it seems to attract no end of attention, this. So I actually emailed Dr. John Conley, who impressed me with his handling of groceries, because he sent me a list that when he comes home, first of all, he wipes off anything dirty. He then washes all fresh produce. Then he wipes off the condensation on the milk cartons before he puts them in the fridge. And then he puts the things by the back door, and then he washes his hands. So I think you could customize that a little bit more, but basically put it away and wash your hands.
On the chat line, Raj Bardwaj is suggesting that you dose everything with ethyl alcohol before... no, he didn't say that. I'm lying. Sorry, Raj. Marinate it. Methyl alcohol versus acetic acid vinegar.
Use the real stuff. I wouldn't fiddle around with vinegar or whatever.
Doesn't taste so good. So listen, don't put down that instrument. What about azithromycin, evidence around that?
Very, very soft. It again comes from the French health, it comes from Trump and French ministry that talked about hydroxychloroquine and azithromycin in really sick people seemed to drop viral shedding in a small study that didn't have outcomes on whether they survived intensive care well. So soft evidence, probably because of the dearth of any good ideas. If it was a Hail Mary, not a terrible idea. But remember, they come with all their own toxicities, and you don't just throw drugs at people in case. You might get a terrible QT fatal issue with some of these drugs.
Yeah, or C. diff diarrhea, and it's not a good time to be having that.
Rick, and if I could circle back to the grocery question, I just had an amazing idea that I'll just ask my teenagers to put away the groceries. I'll leave them in the car for 2 days because it'll take them that long to put away the groceries, and by then the virus will be dead based on your earlier comments. Is that accurate?
Oh, very accurate.
Okay.
The fresh produce might be a little bit past its best before date, but it will work.
I'll work on that.
The ask a teenager strategy. You heard it here first. Listen, we're approaching the end of our time, and what I'm going to do is I'm going to invite each of our speakers to maybe highlight one key message that they would like to give to the audience to be able to take with them into practice or life tomorrow. And I'm going to do this in reverse order. Jia Hu, I'm going to ask you for your pearl that you would like to leave this group with.
Yeah, I think the pearl is like the same as the last pearl I gave, which is sort of, we're entering a period, I think, where we're going to see more cases and possibly a surge in hospitalizations, ICU cases, and deaths, right? And I think we need to all be ready for that. And I think we might be called to do things we're not used to normally doing. But I think we're well trained, and I think we're going to do a good job of it. So, seriously, now is the time for, healthcare workers to really sort of shine and protect society. So, I think support is always available. People can always email me, and I'll get people the best answer I'm able to. But, I think we shouldn't. We're ready. We're prepared. I know there's going to be fear, but, we're going to get through this.
Thanks. Great words. John Gill.
Don't get too depressed by the scenes of the very sick struggling and a healthcare system that's struggling. 80% of people will do really well without too much being done to them. And remember that, and there may be some people who've been infected who are immune that we'll find out when we get serology. So the media will, of course, focus on the worst case scenario, very sick, not enough ventilators, or using one ventilator for 2 people. That is the rarity. Most people will do well, but let's give them the best chance by pushing the curve down the road so that the workload will be defrayed or dispersed across the healthcare over many months.
Happiness is a flat curve. Margie Oakander.
Remember trusted sources for your information, like tonight. Limit your social media, cut off the feeds, cut off the fake news, all of that, and rely on those trusted sources. Physical distancing, not social distancing, keeping up those social connections, reaching out to people, talking, and staying connected that way. Maintaining a routine, exercise, healthy eating, trying to keep the structure in your day as much as you can. Focusing on the positives, remember that rear view mirror if you're still at work, leaving that behind. Grounding yourself, clearing yourself before you get in the door, and really trying, I echo what John's saying, try to focus on the positive things that are coming out of this because we're hearing so much of the negative.
Thanks, Margie. And the last pearl will come from Christine Luelo.
Okay, so I think in particular as family doctors, we have great relationships with our patients, and we're doing care in a different way, and so we can continue to provide amazing clinical care. But remember to give every one of your patients a really big dose of compassion, calmness, reassurance, and don't forget to give yourself the same thing.
Good words. So just to end things off.
John's doing the butterfly hug.
The butterfly hug. Okay, that's right, butterfly hug. That's the best we can do in socially distanced times. physically distanced times. Next steps for us is we will send out the BMJ link for that very practical and very timely article. We will send out the link on the Roth test and AMA Virtual Care. Yes, AMA Virtual Care. That we'll send out that link. Within 24 hours, we will have hard copies of the questions and answers so that you can go back and refer to those. As well, we will have an archive version of this online where we will send you the link. You will get an evaluation for tonight if you are interested in getting study credits. That will come within the next 2 or 3 days. And our plan now is to do this next week, same time, same channel, so we will send out registration materials. If that changes, watch your PCN emails. I would really like to thank, first of all, the people behind the scenes, Bahiji, Keith, Trevor, our sound man, whose name I don't know, and also all of the PCN medical directors. I would like to give a socially distanced show of appreciation to our panelists for great work and great interaction. Jia, thank you once again for being flexible and joining us electronically. And thanks to those frontline family docs out there doing the good work. Thanks very much for tuning in. See you next week.